Well, a rather short talk in which we go through some of the glaucoma management studies. So, randomized clinical trials are hugely important in all aspects of medicine, including glaucoma, and it really behooves us all to understand what we learn from these big trials. So these trials have created a foundation of information that supports the management of people with glaucoma, much more so than individual observations or small trials can do. And because of the care that has gone into these studies, the information that's come from them is very important for us all to learn. Some of these trials fit nicely into other sections of the curriculum, and I've included them there. And the reason is because to just go through 12 or more clinical trials in a row would be really pretty mind-numbing. Wherever I include them in talks, I put these little banners on the sides just to let you know that we're talking about a randomized clinical trial, and you really should try to wrap your head around these data because they are the foundation of our practice. So a recent paper, 2015, reviewed the clinical impact of randomized clinical trials in glaucoma. This is based on a survey of members of the American Glaucoma Society, so of course it's America-centric. Some members are parts of some of these trials. And they listed 8 randomized clinical trials in order of physicians' view of the impact that they've had on their clinical practice. So these are the 8 that were listed. Ocular hypertension treatment study, very important, and all the way down through this list. Most of these I've covered in other talks, and so I show you here, for example, OATS study we talk about in section 15, and you can see the list. There are 3 that I haven't talked about elsewhere, and so I'm going to talk about them here. There are also some other randomized clinical trials that I've talked about in other sections of this curriculum that weren't included in that list. The LOGIT study for looking at the comparison between using brimonidine and timolol for normal tension glaucoma. The fluorouracil filtering surgery study, which doesn't get referred to very much anymore, but it's really what opened up the whole field of using anti-metabolites in glaucoma surgery. So it's had a huge impact on us, even though we don't use fluorouracil much anymore. And then a newer ongoing trial, the Ahmed-Barvelt comparison study. So those are all reviewed elsewhere. Now we're going to review these 3, Advanced Glaucoma Intervention Study, or AGIS, Collaborative Initial Glaucoma Treatment Study, or CIGTS, and then the European Glaucoma Prevention Study, the EGPS. The Advanced Glaucoma Intervention Study asked the question, is it preferable to use trabeculectomy or trabeculoplasty first in the treatment of glaucoma? And the design was that patients were assigned to one of 2 algorithms. They either received trabeculoplasty first, and then if that failed, they had trabeculectomy, and then if that failed, another trabeculectomy. Or they had trabeculectomy first, and if that failed, trabeculoplasty, and then trabeculectomy. So the ATT and TAT were the 2 treatment groups. And the answers were that in Black patients, the ATT sequence resulted in less vision and visual field loss. So for patients of African heritage, starting with trabeculoplasty was preferable to starting with trabeculectomy. In white patients, the opposite was true. People had less loss if they started with trabeculectomy, then had trabeculoplasty, and then trabeculectomy. This study showed that lower intraocular pressure was associated with less visual field loss. People who had trabeculectomy had an increased risk of cataract formation. And they also showed that intraocular pressure fluctuation was an independent risk factor for worsening in patients with lower baseline intraocular pressures. The Collaborative Initial Glaucoma Treatment Study, CIGTS, in this the question is it better to institute initial therapy with medicine or with surgery? And some of this came out from observations in the United Kingdom, where they often would go to surgery first, that people who had surgery without having all of the conjunctival irritation of medications had a better outcome. So the design was a random assignment to either medicine first or trabeculectomy. The study found that pressures were lower in the surgery group. However, there were similar rates of visual field loss up to 9 years of follow-up. There were more cataract and early vision loss in the trabeculectomy group, but over time, these lines converged. And quality of life measures were similar in the two groups. The problem with a lot of these studies is that they were started when the medical options were poorer, so prior to prostaglandin analogs, for example. And who knows how this would play out today. Lastly, the European Glaucoma Prevention Study. We don't hear a lot about this study in the U.S., and partly, I think, because it really doesn't support the way that we practice in some ways. The question is, does lowering the intraocular pressure prevent glaucoma damage? It seems like a ridiculous question, but back in the 80s, there were studies questioning the treatment of glaucoma, whether or not there was proof that lowering pressure prevented worsening glaucoma. The normal tension glaucoma treatment trial certainly addressed that, and the OATS trial, and I don't think there's any question these days that this is an issue, but at the time that this study was started, that was a question. The design was that patients were randomly assigned to treatment with either dorzolamide or placebo, and the placebo was all of the same stuff that's in dorzolamide, just without the active component. And the answer was that the pressure lowering in the treatment group was small, 22% at 5 years. And the thing that was really unusual about the European Glaucoma Prevention Study was that the placebo group also had a marked reduction in intraocular pressure, almost the same after 5 years. The drop in pressure in the placebo group was surprising to everyone. Some thought that maybe it was regression to the mean. In other words, you start therapy with the pressures the highest. Even if you do nothing, it's more likely to go down than to go up. There was no difference between the groups in pressure or progression. And this was not a small study. There were over 1,000 patients in this study. There was concern that there was a high rate of attrition from the study. 30% of people who were enrolled did not complete the study, and the attrition rate was higher in the dorzolamide group, presumably from the stinging that people can get from dorzolamide. Because the design was similar to the OATS study, it showed many of the same things that the OATS study had shown. The risk that comes from having a thin central cornea, older age, higher pressure, larger cup-to-disc ratio, higher pattern standard deviation on Humphrey Fields. So, the key points. Randomized clinical trials form the foundation of many of our practices in glaucoma. It's important as a student that we're familiar with all of the major randomized clinical trials. The AGIS showed that there was a racial difference in response to trabeculoplasty or trabeculectomy. More darkly pigmented patients do better starting with trabeculoplasty, more lightly pigmented patients starting with trabeculectomy. It also showed that a lower intraocular pressure was associated with less risk of progressive glaucoma loss. CIGTS showed a similar efficacy in patients treated with medication first versus those who were treated with surgery first. It showed that trabeculectomy patients had more cataract than medicine-treated patients. And the EGPS showed little protective effect with dorzolamide versus placebo. Also showed the same risk factors for progression as we're seeing in the OATS study. And sometimes you'll actually see the data from the EGPS and OATS combined together to give a bigger data set. So again, throughout this whole curriculum, you will see randomized clinical trials presented. Really try to wrap your head around what the trials are showing. Some of them are less relevant today because they were done at a time when there were different medications, but they really are the cornerstones of how we practice medicine.